You, Steve, and can I just say masterful agenda keeping because we are to the minute with that transition, folks. That is so impressive. So I can't let the slide down now. I have to keep to the timing that was allocated. Um, yes, as we just saw, we have a huge breadth of teams represented here with folks with decades of experience and some of you who are in this area. Could you do the next slide, please, Judith? Thank you very much. So, our aim with this initial didactic is just to ensure that we are all on the same page in terms of how we are defining clinical high risk, some of the context and some of the history of this work, and then thinking a little bit about some of the questions that this work might also bring up. Although I'm not promising any answers to that today. That's going to be what we hopefully develop over the next few sessions. Could you do the next slide, please? Thank you. So broadly, we can think about this idea, this concept of early detection of psychosis as the identification of young people who are at risk of developing psychosis and any subsequent intervention that aims to prevent, delay, or ameliorate transition to psychosis. That was kind of just pause there for a second. That was the backbone of the work as it sort of originated. And more recently, we've been able to think about this much more through the lens of addressing current distress and functioning, with some of the focus being taken away from just that transition as an outcome. Next slide, please. And another important page to get on in the same sort of orientation is just understanding the differences in terminology, or the fact that there is different terminology used here in the US and also internationally. As you read research papers, we may see the same period being labeled in different ways. So clinical high risk for psychosis, most commonly used here in the US, ultra high risk or at risk mental state. Frequently, these are used interchangeably. At times, they may be used to define different things, a more heightened risk potentially. Where we are able to align these days, which again is a more relatively newer development, is that we don't refer to this period as prodromal. That is a retrospective term that we can apply. So once somebody has gone into the full transition or transition into full psychosis, sorry, then we can look back and say that that period leading up to this, where we started to see changes, was the prodrome. But as you'll know, and as we'll talk about, and as we'll touch on a little bit in the coming slides, the clinical high risk period is not an inevitability of transition to psychosis with or without interventions. And so to call it a prodrome would be inaccurate and just not a helpful term for us. So generally, we have been able to shift now to this more accurate language. Next slide, please. And so this period, the CHRp period, and I'll keep using CHRp since that's the more accepted and broadly used term here in the US. We're seeing it as a very early form of psychosis, but by its nature, the definition, it has to have features that are distressing and impairing to the individual. That for anybody identified as being in this period, there is a heightened vulnerability to developing threshold psychosis, although not an inevitability. And as we've touched on, this is not a prodrome to psychosis. Next slide. And just sort of centering this within the broader concept of this sort of trajectory of psychosis. And you'll see along the bottom there, I've put the typical question mark course of psychosis because I always get nervous whenever I call anything typical or overgeneralized because, of course, as we know with working with individuals, things can look very different from individual to individual, but broadly and very generally, what we see with the onset and sort of development and evolution of psychosis symptoms is this sort of pre-morbid phase where everything's going fine. Development of non-specific symptoms like depression, anxiety, maybe some changes in behavior or functioning, into the attenuated symptoms of psychosis, so the symptoms that don't meet criteria for full threshold psychosis, but are enough there for us to start to be curious about what's going on, into full psychosis symptoms, and then potentially ongoing symptoms or not, depending upon treatment response. And that dotted line there is that threshold. It's the crossing over from attenuated into full. Once we've gone over there, we're doing our early intervention after the onset of psychosis or our coordinated specialty care models, as we have here in the US. Preceding that line is our early detection efforts of clinical high risk. And that line, as you will all be familiar, is somewhat drawn in the sand sometimes, but it's our transition to full conviction and impact on behavior or functioning. And as you'll know, it seems like a very clear-cut definition, but for any of you who've sat in meetings and discussed SIPS scores and tried to establish consensus and whether it was a 5 or a 6, or wouldn't it be nice if we could have a 5.8 because it hasn't quite, right? We know that in reality that line is, it can be a harder to define, although easy for us to explain to folks. Next slide, please. Thank you. And I always find this a really helpful graphic to think about, again, like where are we situating this work? This, I've lost the reference off this one, I'm afraid, in the transition, but it's Mozak and Haggerty from the Institute of Medicine. And actually, Steve was sharing with me, I've shared this slide for more years than I care to remember at this stage, in terms of talking about this work. And then Steve was like, oh no, there's a whole extra section that's not on there. And I was like, really? So he also was talking about how, another graphic of this, another diagram, another example of this, there are wedges for prevention that are about more of the promotion side, health promotion, outreach into the community, that kind of thing, which is very relevant, of course, for the clinical high risk work. But here, if we think about those 3 green cheese wedges, not a fan of green cheese personally, but here we are, green cheese wedges of, oh, thank you very much, Steve. Those 3 green cheese wedges in prevention. We have universal prevention, selective, and indicated. Universal would be things like interventions happening at a population level, like vaccines or fluoride in the water. Obviously, that would be unethical and would not make economic sense if we were thinking about psychosis. And also, there wouldn't be a treatment target for that either. It just wouldn't make sense just for us to take a universal approach in that way. Selective is narrowing things in a little bit more. And if we think about it through CHRp, this might just be identifying individuals who have a first-degree relative with psychosis or with a schizophrenia disorder diagnosis. As we know, however, if we were to take that approach, genetic risk is only one risk factor, one component of clinical high risk presentation. And so if we're doing that, we would miss a whole host of people who may benefit from identification and intervention. And so we move up a cheese wedge into the indicated, and that's really where we've settled in terms of identification of indicated presenting features, such as attenuated symptoms that are causing distress and also impacting functioning. And again, I find it helpful just to use this to situate where in the larger scope of things are we really focusing this work before we start to get into the early intervention of illness identification, treatment, and standard treatment. Next slide, please. All right. So that's our context, that we're all on the same page. It's a shame we're not in the same room because then we could have an argument about whether we all agree with that or not, or if there's deviations. And, it is still a relatively nascent field. And the reason why we chose to do some early definition with this is because it has at times been quite a nebulous concept. So I wanted to make sure we're all on the same page before we do this sort of brief step back in time, also known as the history of CHRp according to Kate. Next slide, please. So, although clinical high risk work still feels very new in a lot of ways, although we heard from folks as they're introducing themselves that many of these programs have been around for quite a while now, which is absolutely fantastic. But if you go and speak to colleagues outside of this field, this still is kind of revelatory to people. And yet the concept of this work has been around since the 90s, if not earlier. Pat McGorry, for those of you maybe who aren't familiar, sort of like the godfather of some of this early intervention work out of Australia, wrote this paper back in 1998, really arguing for the importance of preventive strategies in early psychosis. And it's like partway down that it was highlighted, we've lost the highlight. Um, this paper's outlining a rationale, logic, and model for realistic preventive efforts in early psychosis care, focusing on indicated prevention in the pre-psychotic phase. So going back to our Institute of Medicine cheese diagram. Can you click forward, please, Judith? It should have a little call out box. It does. Beautiful. And Pat also references, if we're sticking with the history for a second, just how, again, these concepts have been around for some time. Referencing Kraepelin, who was really emphasizing the importance of early diagnosis with dementia praecox, as it was known at the time. And Loyola talking about the importance of supporting restoration or return to the earlier life and to functioning as supporting the best outcomes. So again, newer work and many, many advances, but this context, this work has been there and we're building upon these really strong foundations. Next slide, please. And this really is the history of the world, according to Kate. It was far too busy a slide to put everything on here, so pulled out some of the key moments in the US history of early detection and clinical high risk work. But before we go into this, I really want to highlight, and that's not just my eyes, that is quite hard to read. I apologize. I'm sure we're sharing these slides as well, so you'll be able to put your reading glasses on and screw your eyes up a little bit. But highlighting again, this is no way a comprehensive and exhaustive list of all the work that has been done internationally or even just here nationally in the US. And it certainly leaves out many of the very, very successful international collaborations that have occurred to drive this field forward. Having said that, just touching on some of the highlights, what we had sort of back in the 80s and 90s was the early recognition of prodromes. And I use the word prodrome there because that was really where it was focused. It was looking at individuals who had developed psychosis or schizophrenia and then being curious about what did the period preceding that look like. It was much more genetically oriented work and very observational. There were no assessments in place to really define this period. We then move forward to sort of the 80s and 90s, and out of the work that was happening internationally around early intervention and psychosis from Australia and Europe, we saw an increase of work happening here in the US in many of the academic centers like Yale, UCLA, Emory represent, I know you're here today. I'm beginning to think about this period within early adulthood as a key period of risk. I'm beginning to move less from this observational to what would a structured assessment of this period look like? If we've defined this as something that's risky for transition, how do we conceptualize that? How do we better assess and understand that, which led us really nicely into the really influential development of the CHRps and the clinical high risk models in the 90s. So initially, the CHRps, a structured interview for prodromal syndromes or symptoms as it was known then, and the structured interview for psychosis risk symptoms as it is known now, massively shifted things forward as it operationalized attenuated positive symptoms. It allowed for the identification of attenuated symptoms focusing on conviction, distress, and impact on behavior, and established the attenuated positive symptom syndrome. And I think a couple of you might have referenced as you were introducing yourselves some of the studies that we saw in the US, so around Naples and EDIP. I think a couple of sites represented here, participants within EDIP. So Naples, the North American prodromal longitudinal study from the 2000s and still ongoing, demonstrating low transition rates that we've sort of seen, and much debate in the field. We didn't have time to get into that today, but much debate around declining transition rates as well. And within the EDIP study, which was a Robert Wood Johnson funded study, sorry, Naples was NIMH, EDIP was RWJ. The EDIP, the Early Detection, Intervention and Prevention of Psychosis program, really focused on testing outreach and intervention strategies across the US and led to, as well, the continued growth of these sites and centers across the country as well. Skipping forward in 2000s to 2013, we had a new DSM, a DSM-5 being developed and published, and much debate and controversy over whether attenuated psychosis syndrome, or APS, would be recognized as an official diagnosis. It was a great time to be alive if you were geeky about CHRp and early psychosis, because there was just back and forth in the journal articles and at conferences about whether this made sense or not. So supporters of inclusion of APS within DSM-5 really argued for the increase in terms of access to care and sort of the recognition of the need to provide interventions to this diagnostic group. That's the direction it had gone. However, those who were critical of this approach or of its inclusion in DSM-5 raised issues around false positives, over medication potentially, pathologizing youth, and any racial bias that we've also seen as sort of inherent in some of this work, and only recently, I think, beginning to sort of figure out a little bit better. But from all of these kind of like back and forth and debate, it was decided that APS would be placed in the conditions for further study section. So it's snuck in the back, not there as a diagnostic criteria. Really wonderfully. And again, many of you talked about your funding from SAMHSA to support the development of CHRP sites across the United States. And again, this has been absolutely game changing because it really has allowed us to look at the development of these programs and to evaluate those outcomes. So the grant has supported evidence-based assessment and specialty care for youth with CHRP. It's really supported local capacity building and improving access and equity. And we've seen CHRP sites funding across many, many states and territories, which has been great. So again, I missed out things. I'm sorry if your thing that you was in isn't on here. You can yell at me later, but touching on the highlights and where we really are now, this kind of evolution and development of this work. So we've shifted now much more from this sort of binary, has the person converted or not, focus and preoccupation in many ways, to much more dimensional, trauma-informed and transdiagnostic understanding of clinical high risk or risk for psychosis and the supports needed. And that shift has been so important and so very much represented and integrated in the services that have been developed. With this, really seeing psychosis experiences much more in a continuum rather than this kind of like binary or discrete entity. And a greater focus, as we've learned more, and as I mentioned, racial bias before, on equity, cultural humility, and addressing social adversity within this work. With the overall goal, as we went back to our definition from earlier, of improving well-being and functioning, not just about preventing schizophrenia or preventing transition. Oh, next slide, please. All right. Here, we are just being very cheeky and throwing out some discussion points. We are not answering these today. We are putting out, these are the things that, if I wasn't so exhausted at night, would keep me up at night thinking about them. Um, because we know, if our tools were really, really good, would we be better at identifying who is going to convert to full psychosis? I know our prediction calculators are coming along, but they're still, the predictive values are still pretty low. So how do we do this? Are we assessing the right thing? Are we missing something here? We could imagine, and this is one of the arguments that's laid out in, I think it's the Moritz paper, that if clinical high-risk services were really successful, we'd see DUP reducing, but we haven't really seen that play out in the literature. So why not? What's going on there? We know that these programs are expensive. So are we getting our bang for our buck? I think things like SAMHSA is really going to help, or the SAMHSA grants are going to help us understand that better. We've got much better at understanding that attenuated psychosis symptoms as transdiagnostic and that comorbidity is common, but we still silo it through psychosis and frequently are not thinking it within a broader youth health perspective, which is critical. And a really, really big one is the stigma associated or the potential stigma associated with the clinical high risk for psychosis label. The argument of if somebody hasn't yet developed psychosis, should we be using the psychosis label at all? And there's pros and cons for both of those. Um, it can be very, very frightening for people who haven't got a concept or an understanding of what that word means, or have an understanding of what that means and have seen it not play out well within their family potentially. But equally, if we're keeping it back, and I've been with early detection programs that would only say risk for a more serious mental health problem, that feels kind of less consensual and a little bit underhand, and like keeping information from people. So lots of debate around that from a lived experience perspectives within this are very, very critical as well. And within that, there's discussion and consideration of the potential for iatrogenic harm. So instead of answering these, we're going to leave these as things to ponder. You may have your own concerns and critiques or things you've heard. And this becomes a space for us over the next few sessions to continue to converse and think through some of this. I think that's my last slide. And oh my gosh, I was 2 minutes behind. Sorry, guys. I slowed down my speaking. Steve, 2 minutes behind.
You're doing great. Thank you very much, Kate. Really